You've probably had this experience. You walk into your doctor's office and you say something like, "Hey, every time I do this thing or I eat this thing, this happens to me. I feel like this." And the doctor says, that doesn't make sense because according to the studies, that is not a known side effect of this thing. Why does that happen? Why do medical providers so rigidly stick to these studies? What makes them so great that they seem to be more valid than what the patient says? To understand this, we need to know a little bit more about studies and the concept of something called N, the letter N. Studies are considered the most rigorous when they test something on a large number of people. That number of people in a study is called N. If 10,000 people are in a study, the N is 10,000. A study with an N of 10,000 is very scientifically significant. It means that 10,000 people tried this thing and they all felt this one way or improved this one thing. But when you're coming into the room with your little story, you're just an N of 1. And in the world of science, your little N of 1 is irrelevant. It's what we call anecdotal, which is a large word signifying not scientific enough and therefore not valid. Today, we're not throwing out science, but we're going to put you back into it with this conversation of the N of 1. Welcome to the Medical Disruptor, a place where well-versed humans can ask the hard questions and get evidence-based answers you won't find anywhere else. Our community is always informed, empowered, and science-backed. I'm Dr. E, the NP with a PhD, and I help smart, well-versed humans go from medically gaslit to medically empowered. Guest episodes are where I sit down with clinicians who expand past their training, and solo episodes like this one are where I dig into issues in depth. You can find all of my citations in the descriptions below. Okay, so let's talk about studies. Medicine is built on research. Research with large sample sizes for a reason. A randomized controlled trial, also called an RCT, is a type of study where thousands of people are randomly assigned to different treatments or a placebo. Randomization spreads out the unknown variables like genetics, sleep, stress, so we can narrow in on what the treatment actually does. RCTs are the gold standard because they reduce bias, they account for variation, and they can help reveal what actually improves outcomes on a population level. The key thing to understand is that RCTs rely on a large N, meaning a high number of participants. The larger the N, the more confident we could be on the average effect. And that average becomes the basis of medical guidelines. Insulin for type 1 diabetes, antibiotics for bacterial pneumonia, IV fluids for dehydration. We know all this not from testimonials, not from vibes, but because tens of thousands of people were followed over years and the data was clear. Large N is not the villain. It's the reason we have modern medicine instead of medieval guesswork. These type of studies serve to protect us. It keeps us safe from false claims, bad science, and snake oil. Without large N data, we'd have a chaotic marketplace. Try this, try that, with no anchor. The reason I can say that a class of blood pressure medication lowers the risk of stroke beyond simply lowering blood pressure is because large trials followed people over years, counted actual outcomes, and analyzed them rigorously. That's not a guess, it's evidence. Think about cancer treatments, and diabetes medication, and antidepressants, even knee surgeries. We know something beats placebo, even if the effect is modest. And we know a therapy does more harm than good. We can compare strategies head to head. We can look at subgroups. We can adjust for confounding variables. And then we can write guidelines that help clinicians make safer, more consistent choices. In other words, without large N, we don't have reliable evidence. We have stories. And stories are powerful. They're how we make sense of the world. But stories alone don't tell us what generally works across a population. Large N studies do. Without large N studies, medicine becomes just a marketplace of claims with no anchor. And that anchor has saved millions of lives. Let me introduce one more important term here. Large studies don't just look at whether something helped people. They measure whether the improvement was big enough in enough people to be considered statistically significant. Statistically significant means in this large N, in this large group of people, the results were strong enough that we're confident they weren't just due to chance. They can infer that these results can be repeatable in a given population. So here's where the problem is. Averages describe populations, not individuals. That's not a flaw. It's just the nature of the tool. You can use an average as a compass, but you still need to navigate the terrain in front of you, which is the patient in the exam room. So the key is population level benefits do not guarantee individual benefit. I'm going to say that one more time. Population level benefits do not guarantee individual benefit. Statistically significant does not mean universally effective. For example, we know that antidepressants beat placebo on average, but we also know that some people take antidepressants and do much worse on them. Here's a simple example. You tell your clinician, every time I eat dairy, I get bloated. And they respond, well, I don't know what to tell you. Large studies don't show dairy causes symptoms in most people. Both of these statements can be true. The average finding doesn't erase what happens in your body. Or consider medications deemed well tolerated. That phrase, well tolerated, comes from the distribution of side effects across thousands of people. It doesn't guarantee that you won't be the person who reacts. It means that across the population, side effects were within an acceptable range. But in the exam room, we're not treating an average, we're treating you. The problem isn't that the science is wrong. It's the way we use the science in real life patient care that it's incomplete. Large trials, science, are doing exactly what they're designed to do. Tell us what works on average. The flaw happens when clinicians apply those averages as if everyone is average and they ignore the individual in front of them. This tension is not a flaw in the science, it's a gap in how we apply it. Averages describe populations. They do not describe individuals. That's not an opinion. It's literally how statistics work. If you say, every time I eat dairy, I feel bloated, and your clinician says, well, most people tolerate dairy just fine, those two statements can both be true at the same time. The large N study is not wrong, but neither are you. This is where medical gaslighting begins, not in malice, but in misapplication. If your experience deviates from the average, you can be subtly told, it doesn't matter. The system is trained to prioritize what is true for most people, even when it clearly isn't working for you. And when that happens, your lived experience gets discounted. Not maliciously, it's usually habit or time pressure or training that prioritizes protocols over curiosity. So it sounds like, that's normal for your age. It's probably stress. Your labs are normal. Just give it time. Translation, your symptoms don't match the average, so your data doesn't count. And this is exactly why we need to discuss this idea of N of 1, which is your lived experience, what you feel in your body. N of 1 means one participant, you. It's not a rejection of science, it's the continuation of it, applied at the smallest possible sample size with the highest possible relevance, your body. Large N tells us where to start. N of 1 tells us whether it's actually working. Think of large N studies like a size chart. They tell you the average fit, but nobody buys clothes and expects them to fit perfectly off the rack without some tailoring or adjusting. N of 1 is the tailoring. It's not optional. It's how things actually fit you. Now let's bring this to life with some real scenarios. If you report brain fog, night sweats, crashing energy every afternoon, but your labs come back normal. Normal doesn't mean you're well. Normal means you fall inside the statistical range of people who were studied for this lab value. But here's the problem. Those studies rarely include people like you. Perimenopausal women, if women are studied at all, individuals with autoimmune tendencies, people with multiple chronic stressors, anyone with early stage dysfunction that doesn't yet meet the threshold for disease. So when you hear normal, what it often means is not abnormal enough compared to the average. The conversation ends there, not because there's no problem, but because their measurement tool, the lab, was designed for disease detection, not dysfunction. So this is where you get lost in the average. Your symptoms are real, your experience is real, but the large N tool wasn't built to see you yet.
All right, quick pause. If this episode is hitting home, check out the Medical Disruptor merch. It's not just a shirt, it's a statement, and every piece helps spread the message. You can find it on my website, drefratlamondre.com. Now, back to the episode.
Here's another way this happens. You'll often hear clinicians say there is insufficient evidence for that. The translation just means there hasn't been enough large studies yet. Not that it doesn't work. It doesn't mean it's been proven to be ineffective. It just means the research hasn't caught up. So if a woman notices that when she cuts out dairy for 3 weeks, her sinus congestion disappears, her bloating reduces, her skin clears, and she brings this to her doctor, and the doctor says there's insufficient evidence to recommend dairy elimination for these symptoms. But what actually happened? In reality, all he's saying is that there aren't enough large N trials studying dairy elimination in perimenopausal women with sinus symptoms and bloating. The absence of the large N data does not erase her N of 1 outcome. Her symptoms resolved. That's clinical data. It's not an opinion, it's not a placebo, it's an outcome. In cases where large N evidence hasn't been built yet, your personal pattern is not only relevant, it's the best data we have. We need both. Large N without an N of 1 is impersonal and promotes gaslighting. But if you only have a world where everything is N of 1 without large N, that becomes ungrounded. So this is not about choosing sides, it's about integrating both. A large N gives us the safety rails, and N of 1 tells us how to drive. Large N is the standard size chart. It gets you close to what works for most bodies. But if N of 1 is the tailoring, the pins, the hems, the seams adjusted until the plan fits your life. If we only trust the size chart, you leave with something that technically fits but rubs you the wrong way. But if you only tailor without a chart, we waste time reinventing a perfectly good pattern. The win is both. Begin with what's proven and then tailor it to you. Here's what that looks like in practice. As I said, you begin with the guidelines. That's the size chart. It's the safest first cut. You layer in your data. That's the fitting. Maybe it's your past medical reactions, what your wearable shows after dinner. And then you run a mini trial, and I'll talk to you about how to do that in a moment. That's the alterations. One lever, one outcome, reassess after a few weeks. And then the last part is reassessing and adjusting again, and that's the final fit. This is where science with a proper fit, and this is actually the antidote to medical gaslighting, not by rejecting the science, but by completing it. So how do we do an N of 1 testing?
Okay, quick break. If this episode is hitting home, just ask yourself this. Are you gaslighting yourself without even realizing it? I made a free guide called Self-Gaslighting Habits to Watch For. So if you're constantly second-guessing yourself in the exam room, this is your starting point. Check out the link in the description. Now let's get back to it.
First, you have to remember that your body is a valid source of data. So the first step is you have to define the outcome that matters. Don't just say, I want to feel better, but choose something really observable. Afternoon energy, sleep onset time, number of bathroom trips, a pain score, and then change one variable at a time whenever possible. If you change 5 things at once, you won't know which lever moved the needle. And track long enough to see a pattern. A week might be enough for sleep, but it's too short for joint pain or menstrual cycle symptoms. And then share what you find. Your notes don't replace the labs, but they do contextualize them, and your patterns can help your clinician fine-tune the plan. In the exam room, the real study is you, especially when what works for most didn't work for you. This is not anti-science. It's science applied to the smallest sample size with the highest personal stakes. So if a medication is well tolerated in trials, but you crash on day 3 with headaches, dizziness, and zero focus, that's data. If the guidelines say insufficient evidence for intermittent fasting, but you try it and your glucose stabilizes, your sleep improves, and your brain fog lifts, that's data. If you track your migraines and discover that 2 late dinners a week correlate with next day headaches, no, it's not an RCT trial, but it's certainly data. Now, before we continue, a small little practical, let me draw a quick line in the sand about what I'm not suggesting, okay? I'm not advocating for DIY drug trials or risky combination or pushing through unsafe symptoms in the name of an experiment. N of 1 is empowering, but of course it needs boundaries. So here are the things we're not going to do. We're not going to stop meds abruptly. If a drug seems linked to symptoms, document the pattern and then call your clinician. Deprescribing is a skill, and sometimes we need to taper off medication. Avoid everything at once. 10 changes means no clarity. Okay, precision is important here. Change one lever at a time. And respect red flags. New chest pain, neurological changes, fainting, severe shortness of breath, blood in your stool. These are not N of 1 projects. These are emergencies, and you have to seek care immediately. So N of 1 is science. It's tailored science, but never an excuse to ignore the risk. Okay, we got that out of the way. So let's get into the practical tools. This is where N of 1 becomes something you can actually use, not just understand. How do you make this real without turning your life into a spreadsheet? First, remember, your experience is valid data. You don't need to track everything. In fact, tracking too much is how most people give up. Choose a few variables that really matter that you're willing to capture consistently. Choose something to track, whether it's symptom intensity on a 0 to 10 scale, a sleep window, lights out, wake time, movement dose, how many minutes walked, meal timing, not just what you ate, but when you ate it. Or maybe you want to track a single biomarker like your fasting glucose or your post-meal glucose or your HRV. Or maybe you want to track your menstrual cycle. Once you've picked 2 to 4 max, then you have to test them well. Remember, change one variable at a time. Decide the test duration up front. Do it before you start. Is it going to be 2 to 4 weeks, 8 to 12 weeks? And then if certain confounders happen, just write them down. If you traveled, if you had an illness, a major stressor, don't give up, but also don't chase that noise. Just write it down as you continue tracking. And decide your success criteria before you start the experiment and write it down. For example, if night sweats drop by 50%, I'll be happy. If I fall asleep within 20 minutes on 10 out of 14 nights, that's a success, right? So write out what you consider a successful moment. Now, sometimes I hear from patients, what if I fail my own experiment? There's no failure. There's only information. If the intervention didn't help, you save time by not clinging to it. If it helped you a bit, great. Then you know what to iterate. If it helped you a lot, you've got a keeper. Every outcome gives direction, and all 3 outcomes are wins. Now, you might have a little bit of an emotional moment when you go through this, because when you've been told you're fine long enough, self-doubt creeps in. You start to second guess your own data. This is a side effect of medical gaslighting. It teaches you to distrust your own senses. Reclaiming this N of 1 is not about fighting your clinician. It's about rebuilding your inner signal. You're not being difficult. You're being data-driven about the only body you'll ever live in. Learn to trust yourself. Say this out loud if you need to. My experience is not anecdotal. It's evidence. Okay, so you've done your experiment. You've collected your data. The next thing is how to bring this to your clinician. Now remember, you're not asking them to abandon guidelines. You're asking them to help apply them to you. Summarize everything on one page. Don't bring the whole binder in, and bring it into the next visit. Here are 4 conversation starters that shift an appointment from dismissal to partnership. 1. I respect the guidelines and I've read them. I also ran a 2-week experiment and tracked sleep onset and night sweats. Here's the summary. Can we look at this together? 2. I'm not asking to throw out the standard approach. I'm asking to personalize it using my data. 3. If this medication is our best choice, I'm willing to try it. Can we plan a check-in at 2 weeks and define what success looks like? And 4. I hear you that my labs are in range, but my function isn't. Can we explore what might move the needle on daily function? These statements are calm, collaborative, and anchored in the shared goal, better outcomes, not blind adherence. They also make gaslighting a little harder because you've put the facts on the table, and a thoughtful clinician will welcome this level of clarity. Now, some of you might say, oh, you don't know my clinician. They are definitely going to dismiss me. What do I do if my clinician dismisses my log? If someone dismisses your log, that's a data point about the relationship, not about your worth or your accuracy. You deserve care that sees the full picture. If the clinician mocks, minimizes, or refuses to engage your documented patterns, that's medical gaslighting. You can say, these patterns are affecting my daily function. Could we integrate them into the plan? If the answer is still no, consider a second opinion. Your data is not inconvenience, it's clinical evidence. Now, a quick aside to any clinicians who might be listening, okay? Just hear me out for a second. Come on in for a minute. It's okay. Here's what I want to say. N of 1 is not the enemy of your training. It's a way to practice the art of medicine without abandoning science. It's what bridges population-based evidence with patient-centered care. It's the very core of why you went into medicine. In practice, it's super small. Invite one measurable goal. Ask what outcome would feel like a real win in 30 days. Document the plan as you would any intervention. Make it chartable. If the patient pattern conflicts with the guidelines, talk together and say, what risks are we willing to accept to honor this pattern? And look for a signal, not perfection. Celebrate if the patient has a signal that's indicating something. Patients don't need perfect RCT level certainty in the exam room. They need progress. They just need to feel better. And patients feel the difference immediately. It's the opposite of medical gaslighting. It transforms the encounter from protocol-driven to partnership-driven. It's medical partnership. Okay, that's it for my little clinician aside. Although, honestly, if you're a clinician and you're this far into the episode, you're probably already one of the converted. Keep doing what you're doing. Let's get back to you. Some of the common pitfalls that people have when they're doing an N1 experiment. Number 1, all or nothing thinking. I missed 2 nights, so the experiment is ruined. Absolutely not. Imperfect data is still data. Just note the misses and keep going. The trend matters more than a perfect streak. Pitfall number 2, changing too many things. I cut sugar, I moved dinner early, I started magnesium and stopped coffee, and I feel great. That's amazing. But which lever actually worked? Next time, stack slower so you can learn faster. And pitfall number 3 is expecting it to be like RCT level certainty. Your life isn't a lab. You're not running a double blinded study. There's going to be confounding factors, and it's okay. You are not trying to create something to go into a scientific journal. You're just trying to see if something is actually helping you. Let's pull all these threads together. Medicine needs large N studies to tell us what generally works, but real care happens one person at a time. Your pattern, your responses, your lived data are not a nuisance, they're evidence. When you bring even a little structure to what you're experiencing, it becomes harder to dismiss and easier to act on. The smartest care starts with a guideline and then adjusts to you. That isn't rejecting science, it's completing it. So here's your take home. You're not a statistic, you're a data source. The large N tells us what usually works. Your N of 1 tells us what actually works for you. And if you're ready to try a small structured experiment this week, pick one lever, track one outcome for 2 weeks. One lever, one outcome, 2 weeks. That's it. Bring what you find to your next visit. That's how we turn your fine into your herd. That is how we shift from protocols to partnership. That's how we end medical gaslighting, one N of 1 at a time. Well, that brings us to the end of another episode of The Medical Disruptor. This is what medical disruption looks like. Not blaming, but exposing the limits of the training and pushing the conversation forward. You're part of a community that doesn't exist anywhere else. A safe space for people who want real scientific information, but also want to ask questions without being made to feel crazy. Our community is informed, empowered, and science-backed. Ready to go deeper? Go to my website, drafratlamandre.com. It has my book, PDFs, newsletter, and a link for consults. Until then, keep asking questions, keep asking for more, and keep disrupting.